So today we are going to talk about non-traumatic orbital emergencies. Okay, first, the knowledge of the imaging features of the non-traumatic orbital conditions is very important. These conditions include infections, inflammations, vascular abnormalities, retinal, choroidal detachments. It's very important to achieve accurate diagnosis and thereby avoiding permanent vision loss and other potentially devastating consequences. CT is the first line, MRI playing an important secondary role. CT offers image acquisition with high spatial resolution than MRI, and it's suitable for the evaluation of fractures, calcifications, radio-opaque foreign bodies. MRI offers exquisite contrast resolution of the orbital structures without exposing the patient to ionizing radiation. It is superior to CT in the evaluation of orbital soft tissues. The presence of orbital metallic foreign bodies is an absolute contraindication to MRI because the risk of moving the metallic foreign body under the effect of the magnetic field. The first and most common non-traumatic orbital emergency is infections. Orbital infections represents more than half of the primary orbital disease processes. The location of the orbital infection is described with respect to the orbital septum. It's either preseptal or postseptal. The preseptal also can be described as periorbital, and the postseptal is orbital. The orbital septum, it's a barrier against the spread of periorbital infections to the orbit proper. So the distinction between the processes is clinically important. Why? Because the postseptal infections are treated more aggressively to prevent the more serious complications like cavernous sinus thrombosis and meningitis. The periorbital cellulitis or the preseptal infections, it's limited to the soft tissues anterior to the orbital septum. Most commonly arises from the contiguous spread of infections from adjacent structures like the face, teeth, ocular adnexia. Also may arise from local trauma. The cross-sectional imaging demonstrates diffuse soft tissue thickening anterior to the orbital septum without abscess formation. It's just infection, no abscess formation. For example, you can see here, this is a CT scan, and this is here the orbital septum. So everything anterior to it is preseptal. Everything posterior to it is postseptal. Okay? So preseptal, you can see soft tissue, edema, inflammation, as seen here. No abscess formation. This indicates preseptal infection. Orbital cellulitis or the postseptal infection, it's most commonly caused by paranasal sinusitis, which spreads to the orbit via perivascular pathway through the small capillaries and arterioles, will spread from the sinuses to the orbit. So the bone is usually not destructed. It's spread through perivascular, not through the bone. Okay? And the distinctive feature from periorbital cellulitis is proptosis. So when there is a proptosis, it's orbital, it's postseptal. If there is no proptosis, alaykum salam. If there is no proptosis, it is preseptal. Okay? So one feature to look for is very important, is proptosis. If there is proptosis, it's postseptal, it's severe. If there is no proptosis, it's preseptal, it's mild to moderate. You can see here, this is a T1 MRI with contrast. You can see first diffuse enhancement of both pre and postseptal, the soft tissues. You can see ethmoid sinusitis here, and it's spreading into the postseptal, into the orbital region, the orbit proper, resulting in marked proptosis. See this orbit compared with the other one. There is marked proptosis indicating postseptal or orbital cellulitis. Okay? Again, orbital cellulitis, you can see the spread from the adjacent paranasal sinus into the orbital component with the marked enhancement and the presence of exophthalmos. In addition to the preseptal component of infection, there is postseptal component. Okay? And you can see here in the sagittal image there is air fluid level in the frontal sinus. Okay? But again, there is no orbital abscess formation. Till now, it's just infection, no abscess formation. What are the complications that we are afraid from the orbital cellulitis? First, orbital subperiosteal abscess, thrombosis of the superior ophthalmic vein, cavernous sinus or both, bacterial meningitis, epidural, subedural abscesses, parenchymal brain abscess. These are the main complications that we should keep in mind. So now we will move from infections and cellulitis to abscess formation. So orbital subperiosteal abscess is most commonly associated with ethmoid sinusitis. The drainage of the abscess may be necessary to prevent rapid elevation of intraorbital pressure resulting in visual impairment. In addition to symptoms of orbital cellulitis, there is ophthalmoplegia and decreased visual acuity. So first we started with a preseptal infection with no exophthalmos, then postseptal with exophthalmos, then abscess formation with ophthalmoplegia and decreased orbital acuity. We're going from mild to more severe and severe and severe. You can see here, this is a CT scan image. There is ethmoid sinusitis and there is a subperiosteal abscess formation resulting in mass effect on the adjacent medial rectus muscle. This is the medial rectus muscle. It's pushed compared with the other side. It's pushed here, okay, as a result of abscess formation. So you should keep in mind that there is, if there is a displacement of the extraocular muscles, the presence of subperiosteal abscess should be considered. Again, here you can see there is a subperiosteal abscess here, and it's marked here with this. The medial rectus muscle is displaced by the abscess formation. So this is both orbital cellulitis and abscess. We have here three kinds of abscesses. First, we have retroseptal abscess, okay, postseptal abscess here, the A, and we have retrobulbar abscess, posterior to the eye globe, okay, and we have left eyelid abscess, this one. So there are multiple abscesses bilaterally in the retrobulbar area and in the retroseptal abscess and in the eyelid. Multiple orbital abscesses. You can see here there is ethmoid sinusitis, okay, and cellulitis, periorbital cellulitis due to frontal bone osteomyelitis. There is extracranial abscess, this one here, the small one. You can see here there is a small abscess. This is called pot-puffy tumor. This frontal bone osteomyelitis resulting in secondary extracranial abscess, they call it pot-puffy tumor. In addition, there is an intracranial abscess, epidural abscess, intracranial epidural abscess, and extra. So we have this abscess, the pot-puffy tumor from sinusitis with soft tissue abscess formation, in addition to epidural abscess, intracranial, both extra and intra. There is something called dacrocystitis, which is inflammation and dilatation of the lacrimal sac, which is located along the inner canthus. Imaging may be requested to exclude orbital cellulitis. Imaging findings is a well circumscribed round lesion that is centered at the lacrimal fossa, demonstrates peripheral enhancement. Any abscess formation. You see in the medial or inner canthus there is a cystic lesion, okay. This is a CT scan in a 5-month-old boy. There is a peripheral enhancement of the lacrimal sac, which is dilated because of the obstruction of the nasolacrimal duct. So, and in addition, you can see there is soft tissue swelling here, indicating periorbital cellulitis. So there is a two-component process here of dacrocystitis and cellulitis. Something we should keep in mind, although it's not very common in this region, is the CMV-induced retinitis. CMV-induced retinitis, it's very common in patients with HIV infection or with AIDS infection. So without treatment, it causes permanent blindness in most patients within 3 to 6 months, accounts for more than 90% of cases of blindness related to HIV infection. It's usually diagnosed ophthalmologically. However, it may be an important incidental finding at imaging in the population with AIDS infection. Okay, so it manifests radiologically as a uveal enhancement. You can see this is the uvea, and it shows here a focal area of enhancement. Okay, sorry, focal area of fine mild calcification. Okay, in the retina, very thin area of calcification. In the MRI with contrast, you can see asymmetrical uveal enhancement. This is the uvea. It's showing enhancement on the right side, while on the left side it looks normal. So this is a CMV retinitis. This is CMV retinitis. Okay, you see the enhancement in the uvea, but the primary process is original in the retina. Okay. Panophthalmitis and endophthalmitis. From its name, panophthalmitis. There is infection of everything. Okay. It's caused by acute subperiosteal infection of the globe, which may occur after trauma or ophthalmologic procedure, like any sort of surgical procedures of the ophthalmology. Panophthalmitis may lead to globe rupture, blindness, require aggressive treatment with intraocular, intravenous, and topical antibiotics. If therapy fails, enucleation may be the only remaining option. Enucleation means removal of the eye globe. They remove his eye. Okay, you can see a panophthalmitis secondary to post-operative infection in a 41-year-old man with right eye pain, swelling, decreased visual acuity after scleral buccal placement, demonstrating diffuse thickening of the right sclera. This is the sclera, and it's diffusely thick compared to the left side, indicating panophthalmitis. Everything is affected. Now let's talk about some inflammatory conditions. First, we have the most famous is the Graves' ophthalmopathy. It's the most common cause of exophthalmos in adults. Autoimmune condition usually occurs 5 years after the onset of Graves' thyroid disease. The orbital findings include lid retraction, proptosis, ophthalmoplegia, conjunctivitis, and ecchymosis. Classically, spindle-shaped enlargement of the extraocular muscles. Keep in mind this point, there is a sparing of the tendinous insertion of the extraocular muscle. Yani, if the tendon is normal, this is thyroid ophthalmopathy. Okay? The inferior, medial, superior, and lateral ictus muscle may be involved, and in this order: inferior, medial, lateral muscles. Usually there's a mnemonic for that. It's I am slow. Okay? I, inferior, am, medial, slow, superior, and lateral. In this condition. Okay, so if you see superior rectus involved, unlikely to be thyroid ophthalmopathy, because it should start with inferior rectus. Okay, usually bilateral and symmetrical. You can see here the extraocular muscles are spindle shaped. They are enlarged bilaterally, almost symmetrically, and there's exophthalmos more on the left side, and you can see there is sparing of the tendons of the extraocular muscles. Again, on the MRI, there is a T1 fat sat with contrast. There is enhancement of the muscle with the sparing of the tendon. The tendon is normal, it's not enlarged. On the coronal images, you can see the inferior, medial, lateral, and superior. In this order, here all of them are involved. It's an advanced case. Okay. Now, idiopathic orbital inflammatory syndrome, or also can be called orbital pseudotumor. It is the second most common cause of exophthalmos. Is non-granulomatous orbital inflammatory process. Yani it's not a TB, not non-granulomatous. There is no known local or systemic cause, and it's a diagnosis of exclusion. After we exclude everything, then remains the orbital pseudotumor. The symptoms include unilateral painful proptosis, eyelid swelling, typically with a sudden onset, occasionally associated with diplopia and decreased vision. You can see here there is orbital fat strengthening. Okay. Myositis, lacrimal gland inflammation, enlargement, diffuse orbital involvement, including involvement of the optic nerve sheath complex, uvea, sclera. Unlike Graves' ophthalmopathy, there is tendinous involvement of the extraocular muscle. Steroid therapy classically result in rapid improvement. You can see here there's strengthening of the orbital fat planes. There is involvement of the muscles of the adjacent eye globe is also involved. You can see here strengthening, marked strengthening. There is optic nerve. The optic nerve here appear as a lucent band, this tiny lucent thing, Okay, there's exophthalmos. The whole muscle is involved to its tendon. You cannot see even, you cannot distinguish the muscle here. Again, see, the whole muscle including its tendon, it's all involved. Okay, and there's signs of, you think like it's an infection or inflammation of the whole area. The fat is stranded, it's enhancing, it's ill-defined, everything is enhancing. Okay, so this is an orbital pseudotumor. Again here, there is an orbital pseudotumor involving the muscle and the adjacent fat. See, compare with contrast, the fat is enhancing here, it's not enhancing here. The muscle is enhancing to its tendon. So there is involvement of the tendon. However, you should keep in mind this is a diagnosis of exclusion. First you start with post-septal infections, or then you move to orbital pseudotumor. Again, myositic pseudotumor, the muscle is all involved to its tendinous insertion. Optic neuritis involves the inflammation or demyelination of the optic nerve, often manifests as unilateral eye pain and visual loss, associated with MS, SLE, viral infection, radiation therapy, infection, inflammation of the adjacent structures such as the sinuses, and it can be idiopathic. The imaging findings, there is bright T2 weighted MR imaging. Acute optic neuritis usually manifests as a hyper-intense signal, enlarged, enhancing optic nerve. Optic neuritis, inflammation of the optic nerve. Like any other inflammation, there is edema, increased T2 signal intensity, and swelling. Okay? Chronic optic neuritis is classically characterized by T2 signal hyperintensity in atrophic, non-enhancing optic nerve. So, if the optic nerve is enlarged, this is acute optic neuritis. If it is hypoplastic, atrophic optic nerve, it is chronic optic neuritis. Okay? You can see here, it's clearly obvious. This optic nerve is small. This optic nerve is large. Okay? This optic nerve is hyper intense. On T, this is T2. Hyper intense on T2, large. So this is acute optic neuritis. Okay? And with contrast, it's enhancing. The other optic nerve is small. With contrast, still there is some enhancement, but it is small. So this is chronic optic neuritis. Both conditions in one patient. Acute on the right side and chronic on the left side. Perineuritis, it's inflammation of the optic nerve sheath. May mimic optic neuritis clinically. There is orbital pain, decreased visual acuity, optic disc edema characterized by thickening and enhancement of the optic nerve sheath. Because of the similar imaging findings may be seen in patients with dissemination of the tumor cells in the cerebrospinal fluid along the optic nerve sheath, careful clinical evaluation is essential for accurate diagnosis. Yani, sometimes patients with CSF tumor spread, some sort of tumor, brain tumor, spinal cord tumor, I don't know what, it spreads in the subarachnoid space, in the CSF. Optic nerve sheath is extension of the meninges. The optic nerve sheath is just a meninges extending along the optic nerve. Okay, so tumor cells might spread along the optic nerve sheath, resembling perineuritis. You should be careful about that. You should have a look at the brain to evaluate for possible secondaries, for seeding of metastatic cells in the brain. Axial contrast enhanced fat suppressed T1 weighted MRI in a 58-year-old man. There is a right eye pain. There is thick enhancing optic nerve sheath with sparing of the optic nerve proper. Here it's very sensitive evaluation of the imaging finding, because you should be careful to decide whether this is an optic nerve sheath abnormality or optic nerve abnormality. Okay, you should be very careful to decide whether this is normal optic nerve in comparison with the other side or abnormal, because if we said normal optic nerve, there is optic nerve sheath abnormality, so there is perineuritis. Okay, you should be very careful in evaluating this part. Some vascular abnormalities of the orbit. First is the carotid-cavernous fistula. It's abnormal connection between the carotid arterial system and the cavernous venous sinus. يعني بين internal carotid artery and the cavernous sinus at the cavernous sinus, because internal carotid artery, it's within, there is a cavernosal part, intracavernosal part. Okay, this apparent connection may result from trauma, surgery, dural sinus thrombosis. Sometimes it's idiopathic. Spontaneous development of carotid-cavernous fistula has been reported in the setting of atherosclerotic disease, Ehlers-Danlos syndrome, and osteogenesis imperfecta. Clinical manifestations include pulsatile exophthalmos with auscultable bruit, conjunctival ecchymosis, venous engorgement, optic nerve stretching, cranial nerve deficit, and visual disturbance. The imaging findings include proptosis, engorgement of the superior ophthalmic vein, cavernous sinus distension, abnormal flow voids within the cavernous sinus at MR images. Why abnormal flow within the cavernous sinus? Because there will be arterialization of the sinus. The sinus is venous flow. So when there is arterial cavernous fistula, the venous will change into arterial. For example, here, this is a non-contrast T1 MR image showing enlargement of the right superior ophthalmic vein in comparison with the left superior ophthalmic vein. Compare this one with this one. This one is larger. And as we move into the cavernous sinus part, you can see here enlarged cavernous sinus on the right side compared with the left. And you can see multiple flow voids compared with the left. Here, multiple areas of signal loss due to flow void, due to arterialization of the cavernous sinus, due to fistula formation. Superior ophthalmic vein thrombosis most commonly associated with infections such as paranasal sinusitis. Symptoms include orbital pain, proptosis, visual disturbance, periorbital edema, ecchymosis, cranial nerve palsy, and headache. Contrast enhanced CT and MR image demonstrated filling defect within the superior ophthalmic vein, associated with enlargement of both superior ophthalmic vein and the cavernous sinus, engorgement of the extraocular muscles, exophthalmos, and periorbital edema. Because the venous thrombosis is secondary to infection, the standard treatment should include both antibiotic and anticoagulant. Yani infection, سوينا thrombosis. Okay? So we should give antibiotic and anticoagulants. Potentially devastating complications of superior ophthalmic vein thrombosis includes vision loss, thrombosis of the cavernous sinus, sepsis, if the cause of thrombosis is infection. For example, you can see here, this superior ophthalmic vein is normal, small in size, while here it's big, it's enlarged, and there is some sort of filling defect or some hypodensity within the ophthalmic vein. This indicates superior ophthalmic vein thrombosis. Again, you can see here, this is the superior ophthalmic vein. On the right side, it's normal, it's slow, it's nice, while on the left side, it's large. There is no flow void. There is a signal intensity within the vein indicating blood stasis. It's not moving. The blood is not moving here, indicating superior ophthalmic vein thrombosis. This is an orbital emergency. Orbital varices are the most common cause of spontaneous orbital hemorrhage. Slow flow, congenital venous malformation characterized by proliferation of venous elements and by massive dilatation of one or more orbital veins. Most orbital varices have a large communication with the venous system, resulting in orbital varix, distension, and increased proptosis during the Valsalva maneuver or postural change. Orbital varices have small communication with the venous system, are prone to thrombosis and hemorrhage. So, if they have small communication with the venous system, they are prone to thrombosis and hemorrhage. If there is large communication with the venous system, there will be exophthalmos on Valsalva maneuver and postural change. What do we mean by that? If the patient performed Valsalva maneuver, like increased pressure, like cuff for example, the eye will bulge anteriorly. Sometimes it's not seen only in Valsalva maneuver. يعني إلا نخلي البيشنت إنه he cuff حتى يصير exophthalmos, proptosis. Okay? The imaging findings may be subtle. Imaging during Valsalva maneuver may be necessary. بعض الأحيان إلا تخليه in Valsalva maneuver تسوي الإيمجينج حتى تشوف الإكزوفثالموس والengorgement of the varices. مثل varices in anywhere, like in the scrotal varices, in the lower limb varices. Valsalva maneuver, they will distend. The lesions usually enhance intensely after contrast media is administered. Example here, you can see there is orbital varix, and it was incidental finding in this case, enhancing extraocular extracorneal right orbital varix. Compare, this is a normal small vein, this is an enlarged vein. Okay, you can confirm this by just performing the exam in Valsalva maneuver. You can make an ultrasound, orbital ultrasound during Valsalva maneuver, and you can see the vein distending. Here you can see without Valsalva maneuver, with Valsalva maneuver. This is an orbital varix during relaxation, okay, and the eye globe is in this position, and during Valsalva maneuver there is exophthalmos, proptosis of the eye globe. It's moving. Notice the distance behind the line here compared with this one. Okay, definitely there is an increased retrobulbar pressure. Venous lymphatic malformation, they are low flow vascular abnormalities manifest in childhood. They appear as unencapsulated multilobulated masses consisting of vascular and lymphatic channels with intracorneal and extracorneal components. May cause bone remodeling, first noticed after it hemorrhages, causing a rapid onset of proptosis, restricted eye movement, optic nerve compression, or combination of these findings. Recurrent hemorrhage with such malformation produce classic MRI appearance of multiple cysts containing fluid levels or T2 shading from blood products in various stages of degradation. يعني sometimes you can see it look like similar to aneurysmal bone cyst. There are multiple fluid levels or blood fluid levels. Associated with intracranial development, venous anomalies, absence of communication with the systemic circulation, and the presence of lesional stability during postural change help to differentiate them from lymphatic from orbital varices. يعني there is no increased severity during Valsalva maneuver. So these are lymphatic problems. For example, here you can see there is a mass. It's not destructing the bone, it's causing remodeling of the bone, expansion of the bone, mass effect on the bone. Okay, and when there is when we did an MRI image, you can see there are multiple fluid levels, multiple, indicating venous lymphatic malformation. Okay, and they are not increasing in size during Valsalva maneuver. Cavernous hemangioma, although they are not an emergency orbital condition, but we should know something about it. It is the most common benign orbital tumor in adults, especially in women, up to 70% of the cases. Lesions are usually solitary, intracorneal, and they demonstrate slow progressive enlargement over time, often manifesting clinically with a progressive painless proptosis. The image findings include well-defined, smoothly marginated mass surrounded by fibrous pseudocapsule that demonstrates peripheral to central enhancement, like any hemangioma, from outside to inside. Okay, you can see it here. There is a well circumscribed peripherally enhancing intracorneal mass. Okay, and the enhancement is more intense peripherally than centrally, like any hemangioma, any elsewhere. And here on the delayed image, there is complete enhancement of the hemangioma. Retinal and choroidal detachments should be distinguished from each other. We are not evaluating the detachment itself because this is an ophthalmologic diagnosis. We are evaluating for the secondary complications and the cause of the detachment. The predisposing conditions includes diabetic retinopathy, trauma, high myopia, congenital cataract, surgery, congenital glaucoma, sickle cell disease, leukemia, SLE, and metastasis. It's characterized by V-shaped with the apex at the optic nerve, at the macula. You can see here. I don't know whether it's obvious on the viewer, but you can see there is some sort of V-shaped mass or bulging of the retina here. On this image is very obvious. You can see here the apex at the site of insertion of the optic nerve. Again, you can see asymmetrical but still V-shaped, indicating retinal detachment. And here you can see a lens, artificial lens. Choroidal detachment, it's fluid accumulation in the subchoroidal space, a condition that occurs after ocular surgery, trauma, or uveitis, and it spares the region of the optic disc in the posterior third of the globe. يعني, you can see here the same as retinal detachment, but the apex is not at the optic nerve. Okay, it's in the subchoroidal space. This is the difference from the retinal detachment. The possible presence of underlying ocular mass like retinoblastoma in children, uveal melanoma in adults should be considered with retinal or choroidal detachment. Choroidal metastases are the most common ocular malignancy in adults, often secondary to lung and breast carcinoma. Malignant cells gain access via short posterior ciliary arteries. Most metastases are found in the posterior half of the globe. You can see here, this one is choroidal or retinal? It's choroidal. The apex is not at the optic disc. Okay, it's metastasis from breast cancer. Again, you can see here bilateral choroidal metastasis and retinal detachment. Okay, this here the apex at the optic nerve indicating retinal detachment. Here you can see there is diffuse enhancement of the choroid plexus indicating choroidal detachment due to metastasis bilaterally on the here on the in the retina and here in the choroid. Okay. Orbital calcification, just a few points about it. Trochlear calcification, scleral plaques, optic drusen, and phthisis bulbi. Trochlear calcification typically at this location, superior-medial, at the site of the trochlear buccal. Okay. You can see here scleral plaque, some foci of the calcification at the sclera, usually at the insertion of the medial and lateral recti. This you should keep in mind to distinguish from foreign bodies. We see a lot of foreign bodies at this area. The calcification, scleral calcification at the origin of the medial and lateral rectus insertion, while calcification occurs, foreign bodies occurs randomly. Okay, you can see here this eye globe is shrunken and markedly calcified. This we call the phthisis bulbi. This is phthisis bulbi, completely shrunken and calcified globe. Okay. Calcification at the site of the optic nerve, we call it drusen. So this is drusen. Okay. Usually bilateral. It's age related. Sorry? I didn't tell you. Drusen. D-R-U-S-E-N. Okay. So again, just rapid review. This is a trochlear calcification superior medially. At the site of the insertion of the medial and lateral recti, this we call scleral plaques. Okay. If it is completely collapsed, heavily calcified globe, this is phthisis bulbi. If it is at the origin of the optic nerve, it is drusen. Again, phthisis bulbi. This common orbital calcification should not be confused with radio-opaque foreign bodies. You can see here, we might mistake it for trochlear or scleral plaque, but you can see multiple radio-opaque areas, multiple calcifications indicating foreign bodies. These are random sites, not anatomical sites. Okay. Again here, this is a foreign body. If it was here, it's a trochlear plaque, but this is not superolateral, not superomedial. Okay. Post-therapeutic changes and devices. Familiarity with post-therapeutic changes and orbital devices are important because they might be misinterpreted as an acute pathologic conditions. Among these includes lens replacements, scleral buckles, intraocular silicone oil injections, pneumatic retinopexy, and globe prosthesis. Like here you can see this lens, artificial lens. You can see here this what we call scleral buckles. There is radio-opaque scleral buckles and radiolucent scleral buckles. Intraocular silicone injection, you see it in the MRI, in the CT scan as a dense object, and in the MRI will produce an artifact. Okay. The silicone, how to differentiate it from hemorrhage, intraocular hemorrhage? Silicone has a density of more than 100 Hounsfield unit, while blood usually less than 100 Hounsfield unit. To keep in mind. Okay. You can see here this intraocular silicone injection, the difference in the signal intensity between the normal and the abnormal eye globes. Here what we call pneumatic retinopexy. They inject air in the orbital eye globe. You can see it's radiolucent air density within the eye globe. Okay. This is a globe prosthesis. This is a two-piece globe prosthesis. Enucleation, removal of the eye globe, and two-piece globe prosthesis. This is the first piece and this is the second piece. Okay? And that's it. Thank you.